Thank you for joining us today for a Neuro-Urology News interview with the expert. Neuro-Urology News is the periodical of the International Neuro-Urology Society. I'm Glenn Wernberg, and I serve as editor of Neuro-Urology News. Today, I'm delighted to have Dr. Rose Khavari with us. She joins us from Houston Methodist, where she is Associate Professor of Urology and Residency Program Director. Dr. Khavari is the Director of Research at the Center for Restorative Pelvic Medicine. Dr. Khavari received her MD from the University of Texas Medical Branch Galveston and did her urology residency training at Baylor College of Medicine. She then underwent advanced training in continence, pelvic floor reconstruction, and neurourology under the mentorship of Dr. Timothy Boone at Houston Methodist Hospital and Baylor College of Medicine. Dr. Khavari is the recipient of multiple awards, including the 2021 Diokno-Lapides Award. Dr. Khavari has recently been involved in the development and investigation of non-invasive cortical neuromodulation technology to improve voiding dysfunction in individuals with neurogenic lower urinary tract dysfunction. A manuscript from Dr. Khavari and her group, published in Journal of Urology this month, reports the results of a derivative of this technology in individuals with multiple sclerosis. In this pilot trial, the therapy was safe and effective and led to clinical improvements in bladder emptying in individuals with multiple sclerosis. Today, we'll be discussing this trial and its results and implications. Dr. Khavari, thank you very much for being with us today.
Thank you, Dr. Wernberg. It is my honor to be joining you and the International Neuro-Urology Society community.
Dr. Khavari, will you broadly describe voiding dysfunction and current management strategies for this condition?
So I think historically, a lot of people used to refer voiding dysfunction to all sorts of lower urinary tract symptoms until we had the definition by International Continence Society, where there is a very clear definition for voiding dysfunction now, and it refers to an abnormally slow or incomplete micturition, either being just a slow urine flow rate or an abnormally high post-void residual, where it needs to be repeated and confirmed on multiple investigations. Now, the problem is that this is very difficult to measure. There's not a lot of agreement among experts as far as what is the absolute number for post-void residual or what is the absolute value for the flow rate. It's like a broad terminology or definition. We try to use some of the more accepted definitions that kind of showcase the more severe voiding dysfunction in individuals with MS, so we could recruit that group for our study. And I'll tell you exactly what were those definitions, because I think it's important to know what was our inclusion so we can interpret the results based on that inclusion. So we decided to recruit women with MS who had stable MS, had neurogenic lower urinary tract dysfunction for over 6 months or were stable on their medications. And we defined voiding dysfunction specifically for patients who had more than 40% post-void residual over bladder capacity, total bladder capacity. We didn't go with an absolute value of just, let's say, 200 or 300 or 250 of PVR, because we know a lot of neurogenic bladder patients or MS patients have small bladder capacity to begin with. So that PVR needs to be interpreted within the context of the bladder capacity. So that was one of the inclusion criteria. Anybody who was catheterizing or had was dependent on catheterization obviously was included. There's another aspect that ICS kind of touches on it, and that's individuals who may not have a high residual, but actually have a low flow. These are women who are able to get their bladder empty, but it takes forever. They're Valsalva voiders and they just have a low flow. So for us, we wanted to make sure we include those individuals as well. So we used the Liverpool nomogram for women, which captures the voided volume and the flow. And so we defined anyone who was less than 10 percentile, and that nomogram could be included in our study. The second part you asked about, what are our current options or management options for voiding dysfunction? So Glenn, when I was thinking about this study, our team has looked at a lot of LUTS or neurogenic lower urinary tract dysfunction issues in MS patients, both in the storage phase and in the voiding phase. But we decided to do this pilot study in individuals with voiding dysfunction, not so much with neurogenic overactive bladder, because the options are so limited. In year 2020, we really have limited options for these individuals who have severe voiding dysfunction with MS. All we can try is maybe some alpha blockers. We can now consider some sacral neuromodulation, but it may not be as effective. And then at the end of the day, we just hand them a bag of catheters and we say, good luck, here you go. You just need to cath. And it's quite a burden for individuals to start cathing. So we wanted to focus our study, or at least start this process by focusing on the voiding phase of the bladder cycle.
So you used transcranial rotating permanent magnet stimulation in your study. What is this technology and how does it improve upon some previously reported modalities like transcranial magnetic stimulation, for example?
So there are different non-invasive brain stimulation modalities now in the market. And one of the more commonly used that has a lot more data behind it is a transcranial magnetic stimulation. It's basically an electromagnetic coil, like a figure-of-8 coil, but it's fairly large. And it's only one coil that it's held over the scalp, whatever region you want to modulate. And then the frequency and the repetition or the intensity of it is adjusted to either deliver excitatory stimulus or inhibitory stimulus. So you can adjust those parameters to do however you want of the protocol. Then there is another version of that, which is a repetitive TMS, RTMS, which basically is a cycle of these repeated stimulations. And that's what's most commonly now being used in depression, in stuttering, stroke recovery, and a lot of other psychological or neurological abnormalities. And there were actually two small studies, older studies that used TMS, one in MS patients, one in Parkinson's, that did suggest that just the coil being held over supplementary modal area, again, non-neuronavigated, not necessarily guided by fMRI of the individuals, but it could potentially affect lower urinary tract function. So when we were thinking about the modality of non-invasive brain stimulation and trying to think what we should use for our study, for our pilot, I kind of realized that, we talk about the circuits that control the bladder, the work from Dr. Blood, Dr. Griffiths, and we know that it's not just one region that controls the brainstem. There's a whole network of these regions of interest that work together. Either they are activated more or deactivated, but they work together and they're not necessarily structurally connected. They may be functionally connected, that kind of work together and eventually allow the brainstem to turn the switch on. So we thought that only stimulating one region may not be enough. So we may need a modality that does multiple regions. And we came across this TRPMS, which is the transcranial rotating magnetic stimulation. It was developed here at Methodist, and it was used on a stroke trial that had just ended, and they had great results, stroke recovery. So I thought, well, that's great. We can have up to 6 small mini magnet, basically TMS devices, RTMS devices, and we can adjust them where we need to put them and use that. So that was the benefit of it. It was mobile, it was portable, it was small. We could do multiple regions at the same time. We could do excitatory or inhibitory stimulation at the same time. But the magnets were not that strong compared to RTMS, so it only penetrated about 2 centimeters. So just the cortical regions that we could modulate. But I think that was enough for our purposes, and that's what we decided to go with and collaborate with our neurostimulation lab here at Methodist.
Can you describe the design of your recent study using this technology?
So this was a pilot study. I mean, honestly, this was part of my K-23 grant. The first 2 aims were just to explore regions of interest that control the bladder, either during storage phase or voiding phase, do all sorts of bulk analysis and then functional connectivity analysis, and try to figure out what are the regions that potentially could be superficial enough modulate. Yes, ideally you want to modulate the brainstem, the periaqueductal gray or pontometriscian center, but those are so sensitive. There's they control the circulation, breathing, and they're just so deep and inaccessible. So maybe we thought we could find regions that could be surrogate, that could eventually modulate that brainstem. And so the aim 3 was just a pilot, is that can we use a technology to non-invasively modulate these regions? And now we're starting to learn that control the bladder. Again, we had a whole list from the literature, from our experts in the field that contributed to those regions, and then our MS cohorts. Is it safe? Is it feasible? And then we think we're modulating them. Are we really modulating it? That's why we wanted to do fMRI before and after, immediately after, to see that, okay, we think we're stimulating or inhibiting them. Is anything happening? And then would this modulation translate to any change in the urinary symptoms? So that was sort of our second aim almost. And so that's why it was a pilot study with only 10 individuals that we're planning to do.
And what were the main results from the study, and were you surprised by any of them?
So we found out that actually non-invasive brain stimulation with a technology like RTMS, which was a multifocal RTMS, it's feasible. It was safe. We didn't have any side effects from the stimulation in the 10 women we investigated it in. And then we did 10 sessions over 2 weeks. And then we found out that out of those 5 regions that we modulated, there were the regions that actually we were really interested in, that we realized that they had increased or significant change in their fold activation pattern that sort of mimicked normal or healthy individuals or patients without MS patients without voiding dysfunction from our prior studies. And mainly it was like the inferior frontal gyrus, supplementary motor areas. So that was like the neuroimaging results that we were sort of hoping to get to, and we did get that. So the neuromodulation did end up to what it was intended to do. And then we're very excited to also find out that clinically patients did improve. 6 out of our 10 volunteers or participants met the criteria of response. And for instance, not only in those 6, when we looked at the group, we had significantly improved post-void residual over bladder capacity, total bladder capacity. We had improvement in the neurogenic bladder symptom score. So we're very excited to actually see that there's some change. However, the part that we were kind of surprised to see was that with our post-fMRI analysis, we found out that a lot of the deeper connections, regions of interest were also changed to have a stronger functional connectivity or stronger activation. And those were not areas that we modulated, but they're areas that are involved in bladder control. And that kind of supported the idea that there is this network, there's this functional connectivity, that if we can improve the whole process, or with just some surrogates, maybe we can improve the voiding. So I thought that was kind of exciting to see. I think another important finding was that we realized that we did have immediate response clinically, but this response diminished after 4 months, which was important for us to know when we design our future clinical trials. But as anticipated, that result didn't last more than 4 months.
Clearly, this study was a massive undertaking. What challenges did you and your team have to overcome to perform this study?
A lot. So we started recruitment in summer of 2019. We had 2 individuals recruited and COVID happened. So it was very difficult with all the shutdowns and all the unknowns to recruit individuals to come to the Texas Medical Center, one of the biggest medical centers in the world. The parking is an issue with this whole pandemic going on for 2 weeks every day to participate in this study. Right. So that was our biggest challenge. I think I was very fortunate to have an amazing team. I had a research assistant, Quay Tran, and Hamida Rajab was my research coordinator, and they did a fabulous job with recruitment. We actually recruited 11 individuals, and one of them decided not to participate because one of the spikes of COVID happened, so she didn't participate. But the other 10 actually completed the entire study. And that was by the end of 2020. So over 16, 18 months, we had completed our study. So we're very fortunate to do that. But that was a lot of time of anxiety and not knowing exactly where we're going to go, and are we going to even be able to recruit or finish this trial. The other issue was the technical aspect of doing this. We decided to do urodynamics combined with fMRI before and after the neuromodulation. And our protocol involves bladder filling and bladder voiding. So we actually ask the patients to urinate or try to urinate or pretend or attempt. We teach them how to do that at the time when their bladder is full. So they signal fullness, and then we give permission to void. The issue is that these are individuals who already have voiding dysfunction, and so they can't void as well. We know that. So we actually had to aspirate their bladders 4 times and then fill again. And that process of aspiration, I think we had not kind of thought how challenging that would be with all these long wires and tubings, tiny little skinny tubings going to the MRI. And we're on a clock, like the clock was ticking. We wanted to do the entire scanning under 45 minutes. So that part was a technical challenge, but we finally figured it out and were able to do it.
So this was a team sort of effort. What other subspecialties besides urology were represented?
So I'm glad you asked that question. I can actually thank my collaborators here. Now this is a good opportunity for me to thank and acknowledge them. First, I think I would like to acknowledge my sponsor, NIDDK, NIH. Basically, this was a kind of maybe one of those projects that could have not gone anywhere, could have failed, but they supported it. So I appreciate their trust and their support. Houston Methodist Hospital Research Institute also additionally funded my time for this. And Timothy Boone, who's been my mentor forever since my residency, he basically implanted the seed of neuroimaging and neuromodulation in my head. And along the way, he kept pushing me and challenging me and encouraging me to consider it. So he's been my mentor, and he is to this time. The people that I think really contributed to my project were Christoph Karmanik. He's a physicist with our Neuroimaging Center, and he's been involved from the very beginning with all my imaging studies and the protocol designs and the analysis. So he helped me a lot with a lot of the neuroimaging analysis. So Glenn, by all means, I'm a clinical urologist. Like my understanding of brain ends very, very quickly. So I think key of having all these bright collaborators was the key to success. So Dr. Karmanik, Dr. Santosh Helakar was the neurostimulation expert who actually had developed TRPMS, and he's still on my grant, and he's helping me with other projects that we're planning to use different kind of modalities. Dr. Ali Jalali, he's a neurosurgeon who's used a lot of neuronavigation, which we're planning to use. And for this one, we actually did use a vitamin E capsule as a neuronavigation, so a fiduciary marker. So he helped me a lot with that and the development of the project. I have Dr. John Lincoln, who's my MS neurology collaborator. And then I had Kuei Tran, who helped with a lot of the data analysis. She's a bioengineer. And my research coordinator, my superstar research coordinator, Hamida Rajab. So big team, they all helped out, and we got this project done.
Great. What are your next steps?
So we have plans, but I think I want to take this opportunity to kind of highlight the limitations and the shortcomings of the study. Yes, it's exciting, but there are a lot of limitations that need to be noted. And I think addressing those limitations are our next steps. Mainly, this was a pilot. We obviously didn't have any power calculation, but now we have the data. Now we can use this data to actually construct a randomized clinical trial with an appropriate power calculation. So that was a big kind of issue with this pilot study, feasibility study. The other issue is that we didn't have a control group. So we know in neurourology and functional urology that there's a significant placebo effect with our treatments, even in overactive bladder, 30%, 33, 40%. So could this be a placebo effect because if we were doing something to them? Yes, it could. So we didn't have a control. And then when you look at the neuromodulation, neurostimulation studies, you realize that they actually have a pretty large placebo effect with their trials as well. So it could as well be that this was a placebo effect. So I think our next step, not I think, but it is, we have actually applied for 2 grants. We'll see which one of them gets funded. Hopefully one of them at least can get funded. That we would like to do a randomized controlled trial with a blinded arm of neuromodulation. So we can see, is this truly an effect of the regions that we're modulating, or is it all due to placebo? That's where we're going.
Great. Dr. Khavari, nearly half of the INUS members are under the age of 36 years old. Do you have any advice to share with such individuals who are interested in embarking on careers as physician investigators in neurourology?
So that's great. It's good to be part of a younger community that's enthusiastic and it's looking ahead and has a lot of energy and momentum. So yes, I think collaborate. Get out of your comfort zone. Again, we get trained for years and years to be clinicians, but then when you talk to other people, you see that there's a lot of people who are working on the problems that you're interested in: neurologists, neuroscientists, physicists, psychiatrists, neurosurgeons. So collaboration, I think, is key. That's when we realize that we can put our efforts together and answer questions that each one of us are working in our own direction. So I think as urologists that are interested in the field of neurourology, we should try to be that bridge. We will not have the knowledge or the understanding of each individual discipline, but I think being that liaison, being that bridge to cross these disciplines should be the key and should be something that we should think about. The other thing is to be resilient. You have no idea how many grants that I have submitted that has not gotten funded, how many abstracts, manuscripts that got rejected. So just take a look at it, try to make it better, and either apply again, submit it again, be resilient, do it over and over.
Great. Dr. Khavari, thank you so much for joining us today. And thank you all for tuning in to Neuro-Urology News interview with the expert.
Thank you so much.